Hello my dear students, I'm Dr. Vaishali Bharambe, Professor Anatomy. And today we are starting the lung series. So we're going to talk about lungs part 1, part 2, bronchopulmonary segments. Okay. Today it's lungs part 1. Link for other two is given in the description section. Anatomy lungs part 1. So now this is just a broad outline of what I'm going to take in part 1. What will be covered in part 2 and then what is bronchopulmonary segments. You can pause and just read through in case you want to know what is being covered in each of the lectures. Right. So let's introduce to ourselves the lungs. Okay. So you can see here the right lung, the left lung attached to of course the trachea and the bronchi, covered by a pleural sac. I'm sure you've seen the lungs by now. You have a general idea about the pleural sac. We're just going to try and get some more details of the lungs in this lecture. Okay, so let's begin. What are the features? What is this lung and what is this peculiar looking, structure, organ in the body? What are its features? Understand that your lung is spongy, it is porous, it is elastic. Didn't you feel you could compress it quite a bit? Right. It crepitates on touch. When you press it, you can actually feel bubbles inside. Okay. In Hindi we say bud bud. Yeah. Okay. And it floats on water. Why does it float on water? Because of course it's full of air. That's why it's going to float on water. And it's slate grey in color. All this you already knew. Now I have a question for you. Was it like this the day you were born? So what is the difference between an adult lung and a fetal lung? Let's ask ourselves this question. Does the fetal lung, before the baby has taken the first breath, does it crepitate on touch? No, it does not crepitate. There is no air in it. Is it grey? No, it's pretty pink. It is us who keep on breathing in so much fumes and rubbish that our lungs turn grey in color. Babies' lungs are pretty pink in color. It floats in water? No, it sinks in water. Why does the baby's lung sink in water? No air in it, right? Okay. It is solid, it is not porous. So, the moment the baby takes the first breath, the lung changes forever. Okay. So, the before and the after moments sometimes are seen here also in the lungs. Right. So what are the parts of lung? Lung has an apex and a base. It has costal surface and a mediastinal or medial surface. It has anterior, posterior and inferior borders. In your mind, you should be at this point of time imagining that you have a lung with you here, which has an apex, which has a base, which has a costal surface and a medial surface, an anterior border, a posterior border and an inferior border. In your mind, you should have a lung sitting on your table with me now. Okay. So, let's look at these lungs. Here's the apex. Here's the base. Apex, base done. This surface is the costal surface. This surface, which is medial, related to the heart, related to esophagus, trachea, everything, is the medial surface. This sharp border is anterior, this rounded border is posterior, and this sharp border below is the inferior border. These are parts of lung that you should know. Anytime you're asked, you should know which is anterior border, posterior border, inferior border, which is costal surface, which is medial surface. Common sense. Okay. Right. So, what is our progress, students? At the end of this portion, you should be able to tell parts of the lung, its surfaces, its borders. You should be able to tell this much. Come on. So, basic identification of each part and side determination. Let's determine the side of the lung now. Ready? Okay. This is very basic for any anatomy Viva. If you cannot do this, then there's no point in knowing more details of lung. So, you have to know the side. Now, I have some very important information for you or trick for you. Read this carefully. Please pause here. Pause here in this video and listen to me carefully. See, remember, any part can be side identified from 3 dimensions: anterior, posterior. For example, you have a cup here, right? So this is anterior, this is posterior, right? This surface is, in this case, medial, and this ear is lateral. Then this top is a superior and this base is inferior. So it has got 6 directions. So when you are side identifying the lung, you must speak 6 lines. Please remember this. If you do not do this, then you are going to land up losing marks and make mistakes. Come. You must speak 6 lines. I am telling you again. Right. So which part of the lung are you going to put anteriorly? Border, sharp border anteriorly. Posterior, rounded border posteriorly. Superior, apex. Inferior, deep concavity of the diaphragmatic surface should come inferior. What will you put medial and what will you put lateral? Medially, you will have all the hilum and the structures related to it. Where you see hilum has to be medial, right? And what is lateral? The convex costal surface with the markings for the ribs and so on is going to be lateral. If you speak these 6 lines and if you put the lung in these positions, there is no way you will go wrong. The hilum will point to the direction to the opposite side of the lung. So if the hilum is facing the left, the lung is of the right side. If the hilum is facing the right, the lung is of the left side. Got it? So that's how simple side identification of lung is. Some additional features can be used like the cardiac notch and lingula on the left lung. Now some very important questions, listen carefully. Should the student use fissures for side identification? Answer, no. Why not? Because fissures are variable. Question number 2. Should the student use number of lobes to side identify the lung? Answer is no. Why not? Again, this is also such a variable thing. You can have 3 lobes, you can have 2 lobes on both sides. So lobes is not a criteria for side identification. The 6 lines I told you are the only criteria to be used to identify the side of the lung. Is that clear? Please remember this. Okay? Right. Progress at the end of this, student should be able to side identify the lung and hold it in its normal anatomical position. Clear to you? Right. Now, if you're enjoying this lecture, do please like, share and subscribe to my channel and hit that bell icon. Students, I have a beautiful website on which I've got a lot of lectures, downloadable notes and surgical anatomy videos, histology joint label videos, vbanatomy.com. A lot of MCQs also. Link is in the description section. Do visit and explore the website. Right. So now go drink some water and let's begin the second part of this lecture. Come on, take that break. It's important for you. Needless to say, it's important for me too. I believe that every student must learn the art of pausing in the middle of studies. If you pause and you just recall quickly, your mind relaxes, it's ready for the next round. Okay? Come. So now that you know how to side identify the lung, hold the lung in its normal anatomical position and let's study the lung. Okay? Right. Apex base, surface is costal medial, borders anterior, posterior, inferior. Clear? So this is what we have studied. Here is the apex of the lung. So we're going to ask ourselves some important questions. Where is the apex? What are the structures related to the apex? What is the applied importance? And what is thoracic outlet syndrome? Okay, so these are the questions we are going to try and answer now. Come. Here's the first rib, and everything above the first rib is the apex of lung, right? So what and where is the apex of lung? The apex of lung lies above the first rib and cartilage. Relations of apex of lung. Now please use your hands, okay? If this is the apex of lung, it's covered by cervical pleura, of course, Remember, lung is always covered by pleura, visceral and parietal. So imagine there is visceral, then there is pleural cavity, and there is cervical pleura, okay, parietal. Above that, you have another layer called the Sibson's membrane, okay. So above that, it's related to a lot of important structures. So let's try this again. Apex of lung covered by pleura, covered by suprapleural membrane, and then related to a lot of very important structures in your neck. I want you to, at this point, put your hand above your clavicle, okay, see here's the clavicle, put your hand inside, okay, on one side maybe, and this is the gap. If you press it deep, your fingers almost touching the apex of your lung. That's how superficial and exposed is the apex of your lung. Okay? Right. So take a look at beautiful images for you to enjoy the process of learning. This is the lung. It's rising here above the first rib, covered by cervical pleura. This cervical pleura is now covered by Sibson's fascia or suprapleural membrane. Okay, this fascia gets attached to the inner border of first rib and the upper end of which is attached to the tip of transverse process. Maybe it's a way of protecting the apex of lung. And then now you see the fantastic image here. Shows you the suprapleural membrane related to some very important structures, starting with scalenus anterior muscle, in front of that subclavian vein, behind it subclavian artery, and further behind it brachial plexus. In fact, if you are smart, you could put your hand in here. I can feel my subclavian artery going up. You should also be able to feel that. Okay? Come on, try it. Right. So you should be able to imagine at this point the apex of lung covered by cervical pleura, covered by suprapleural membrane, related to these very important structures like subclavian vein, artery and brachial plexus. Okay, why are we discussing all this? We'll come to it. Posteriorly, the same apex of lung is related to 4 structures. You can use the mnemonic S1, S. First thoracic nerve, superior intercostal artery. First posterior intercostal vein, sympathetic chain. S1. Sympathetic chain, first posterior intercostal vein, superior intercostal artery, first thoracic nerve. S1, posterior relations of your apex of lung. What are the structures it's related to in the midline? These structures. So that means what are you seeing? Esophagus, the thoracic duct, the trachea, and a lot of nerves. Can you see there are so many nerves here? Recurrent laryngeal nerve of the left side, right vagus and phrenic, left vagus and phrenic. In the center, it's just left common carotid also seen. So these are all the midline relations. Now, I want you to understand that this is the apex of lung, anteriorly related to 3 important structures: subclavian vein, subclavian artery, brachial plexus. Posteriorly related to S1. Medially related to esophagus, thoracic duct, trachea and vagus, phrenic. Okay, so apex of lung is related to some very important structures, right? Now let's talk about some applied aspects. Why did I discuss so much with you? Because sometimes these structures can be injured if somebody is trying to harm someone. Just take a knife and put it in behind the clavicle. It's going to go directly into the person's apex. I'm not saying try, not at all. Okay, but this is how it is. Worse than that, you have something called as thoracic outlet syndrome. Come. So what is thoracic outlet syndrome? So you should just imagine that there is some injury in this region. Okay, the cause of injury can be variable, but the structures which are going to be damaged are all of these, right? So imagine that you have an extra rib here. Instead of first rib, you have a cervical rib also. Or you have a fibrous band of cervical rib. Or you have hypertrophy or spasm of that scalenus. I told you that scalene muscle going into spasm. Or you can have a narrowing of the costoclavicular. Remember, first rib crossed by clavicle, the gap is narrowed. Or maybe you have a Pancoast tumor. Pancoast tumor of the apical lung, right? So for all these reasons, the apex of the lung begins to get compressed. What symptoms will you get? So first, let's compress the subclavian vein. Because the vein is compressed, okay, the face of the patient can be edematous, the upper limb can be, on that side can be swollen, bluish discoloration of the upper limb because venous blood is not draining that easily, right? Similarly, would you be able to feel the subclavian pulsations? No. Beyond that, would you be able to feel the radial pulsations? They are weak because the artery is getting compressed, okay? The limb is looking cold, limb is looking pale. Now let's talk about the nerves, okay? So pain, numbness, tingling along the medial aspect because lower brachial plexus, remember T1, C8T1 is getting compressed. Ulnar nerve is getting compressed, so the ability to move his hand is hampered. Maybe the phrenic nerve, which is crossing the subclavian at this point, could be also involved, resulting in diaphragmatic paralysis of that side. Or you may have a hoarseness of voice if the tumor is on the left side, compressing the left recurrent laryngeal nerve. So these are all symptoms of thoracic outlet syndrome. And this is asked very often as a theory question. Do please study this. And the best way to answer this is do it systematically. Know your section at the level of T1. Know the apex of lung and its relations and go systematically. Venous symptoms, arterial symptoms, nerve-related symptoms. Then there is more chance of you getting the whole thing correct. Right. So we are now talking about the base. The base is resting on the diaphragm on both the sides. Okay. So inferiorly, first it's related to the diaphragm itself. On the right side also related to the liver. Okay. On the left side related to the stomach and the spleen. Let's talk about the costal surface. The costal surface is convex. It's smooth. But you will see that there are slight undulations. These are because it's related to the rib cage. So every rib is going to create a depression. Every intercostal space is going to create an outward projection on the costal surface. Take a look. You can see elevations and depressions of the intercostal spaces, isn't it? Remember, there are some things which you must never forget. You remember. Come. So this is the thoracic cage. And these are the ribs, 1st to 12th, correct? Now on this I have marked the pleural marking, the extent of pleura, right? So you can see how it's rising above the clavicle in the midline, then it's hitting the 8th rib in the midclavicular line, 10th rib in the midaxillary line, 12th rib posteriorly. This is the pleural marking. What about the lung? Because lung is obviously covered by pleura, right? Come. So you will understand that on the right side, the lung almost follows the pleural marking. Okay. At the level of the 6th costal cartilage, the marking goes laterally, hitting the 6th rib in the midclavicular line, 8th rib in the midaxillary line, 10th rib posteriorly on the right side. On the left side, marking is a little different. Remember, there's a heart there. So at the level of 4th rib, it travels laterally almost 3.5 centimeter, descending down 4 centimeter from midline, and then the rest of it right like the right side, 6th rib in midclavicular line, 8th rib in the midaxillary line. The left lung is slightly longer than the right because the right side is hampered by presence of the liver there, right? So now this is your rib cage, right? And somewhere from here is your apex of lung. Remember, it never rises above the medial end of clavicle. It begins to descend downwards here till the 4th space, okay, on the left side, forming a little cardiac notch here, 6th space, midclavicular line at the level of 6th rib, midaxillary line at the level of 8th rib. And if you turn the skeleton around, 10th rib posteriorly. Similarly on the right, from the sternoclavicular joint descending down till the 6th rib, traveling laterally along the 6th, see this is 1, 2, 3, 4, 5, 6, traveling laterally mid-clavicular line 6th rib, mid-axillary line 8th rib, okay, and posteriorly down till the level of the 10th rib over here, right? So can you imagine that? The same marking when you do on a pleura, what you find is that instead of reaching the 6th rib, the pleura extends down till the 8th rib in the mid-clavicular line, 10th rib in the mid-axillary line, and 12th rib posteriorly. So that means that there is a clear 2 intercostal space between the lower edge of the lung and the lower edge of the pleura. And that's the point we need to make. Every time you're asked to do a surface marking of lung on the cadaver, why are they doing this? Because you need to know that where is the extent of lung and where is the extent of pleura and where should you put your needle to tap the pleural effusion, right? So that is why you need to know the markings on the skeleton, right? Come back to the screen now. So these are the markings and the extent of lung compared to the rib cage, which is actually in a patient, you cannot see a lung. What you can see barely and palpate is the rib cage. So you have to use these markings to be able to mentally project the lungs, right? You will see that between the lungs and the rib, there is a clear 2 space distance. Okay, between the lower edge of the lung and the lower extent of pleura, there is a 2 intercostal space distance. That's something you should note. It is into this space that your lung expands every time you breathe. Does not obviously occupy the whole space. It doesn't need to unless you are taking in deep breath. But that's a potential space into which your lung is going to expand and recoil, expand and recoil with respiration. So I hope you're enjoying this lecture. If you are, then please like, share and subscribe to my channel and hit that bell icon. Students, do please visit my website, which gives you a lot of downloadable notes, other videos, surgical anatomy videos, histology, draw and label and MCQs. My website is vbanatomy.com. Link is given in the description section. So what have we covered up till now? We've covered the apex of lung, thoracic outlet syndrome, base, costal surface. At this point, we need to stop. Lung part 2 will cover the rest. Medial surface, anterior, posterior, inferior borders and much more. So that was lung part 1 and this is going to be lung part 2. Right and left lung and their medial surface, markings, lobes and fissures, and finally there will be part 3, bronchopulmonary segments. Watch all 3 to have a complete understanding of the lung. Okay. Breathing is a very simple act, isn't it? You don't really notice you're breathing automatically. But it's amazing how much connection there is between the structure and the function and between your own functionality. Thank you, students. I hope you enjoyed this lecture. I loved taking it. Okay, I'll see you in lung part 2. Bye.